morning to everyone. It's a pleasure to have this opportunity to contribute to this interesting dissemination series put on by this Society for Clinical Child and Adolescent Psychology. So you can see from my talk, I am going to be focusing on adolescent drug abuse. The first slide gives you a preview of a little bit of my orientation to the field and my, I think, evidence-based view of it. When you're talking about adolescent drug abuse, it's not just about substance use and the direct consequences of that. When we're usually looking at a clinical level of drug use, we're also having to think about other disorders. And for most teenagers that meet abuse or dependence criteria and that end up in our clinics or in a lot of research studies, you're often finding multiple other problems. Some of those up there are a little bit more common in co-occurring than others. We'll talk about that throughout the morning. This is another slide to remind you about my talk. This is actually a formal, brain scan of a teenage brain. It's not a cartoon. It really looks like that inside. It's to remind you that, yes, emotionality, poor decision-making, or poorer decision-making can be common in the teen years. And one of the smaller sections up there, common sense, I'm not sure you can even see it. It's in the little area in the front of the brain. It's supposed to reside there neurologically. To some degree might have or be dominated by other regions of the brain that are more interested in perhaps the fun and action parts of being a teenager. Understanding the teenager, the developmental issues, and even brain development can help sharpen our work. More on that this morning as well. So I wanted to tackle these three objectives, trying to get an opportunity to give you insights on what the literature says, as well as some of our clinical views, organized around these three topics. Developmental issues is going to get some attention by me, and then the last two have more direct reference to interventions and treatment. I'm going to look at the last two somewhat broadly, not just treatment and counseling strategies per se, but I want to talk about assessment issues, service provider challenges, in addition to some of the core components that are like to be important when one is trying to intervene or treat teenagers with a drug problem. Some resources for you. There are some free ones and then some things to purchase and some good articles in literature. These tips 31 and 32 were published in the mid-1990s, so they're a little outdated, but they're still free and you can download them. They still offer some good insights. You may know about this big series. If you're in the drug abuse field, you want to know about tips because they're already up to in the 60s, I think, and each tip focuses on some topic that someone in the field of drug abuse may want to know about. So there's a tip on motivational interviewing. There's a tip on drug abuse with elderly. There's a tip on adolescents. Two of them. One is screening and assessment. Number 32 would be more germane to today. For books to buy. I think there's three I've liked that are edited books, so they have sampled a lot of other researchers and clinicians in the field, so you get contributions of many. The first two are related to treatment. The first one there, the 2011 one, is more of a clinical perspective on treatment issues. The second one is if you're interested in the comorbidity topic and the treatment of it. That's the focus of the Kaminer and Buckstein book. And then Howard Little and Cynthia Rowe's edited book is very relevant to today, since that heavily focuses on treatment strategies and approaches. And then I'm going to highlight one good publication. There's a lot. If you Google Scholar drug abuse treatment and even Google Scholar reviews of adolescent drug abuse treatment, you'll find things from the late 1990s and early 2000s. But I would encourage you to just go right to Lipsey's meta-analysis. Now, it's not in the literature yet. He's compiling perhaps several reports that'll get in the peer-reviewed literature, but his report is available, and I'll be tapping into it as we discuss the field. But it is a meta-analysis. So it turns out we're a little fortunate. If you'd asked me to do this talk 5 years ago, boy, I wouldn't have as much rigor to give you with the topic. But because there's been a lot of treatment research done, in recent years, particularly the last 10 years. Enough studies to do a meta-analysis. Mark Lipsey is a pioneer in meta-analyses for the behavioral sciences. I don't know if you know the conduct disorder or juvenile offender field, but he's done several meta-analyses looking at that arena. He's so good, just a little sidebar, he's so good that there was a major effort by the federal government to understand the problems associated with pathological gambling. So National Science Foundation put together one of those blue ribbon panels so they could come up with a report. And they wanted somebody to do a meta-analysis on the prevalence of pathological gambling. And who do they hire? They figure out who's the best, and they get Mark Lipsey. Interesting report. More on that later. Okay, so how am I going to give you my talk? It's going to be organized around 7 principles. I'm calling it 7 habits of highly effective counselors. Counselors in the field of adolescent drug abuse. So I kind of ripped off Stephen Covey a little bit and going to give you the talk around these 7 principles. They're all related to clinical and research phenomenon. They all touch upon treatment. Some of the principles are direct with treatment. Some of them are a little more peripheral, but hopefully you'll take away a breadth of information that you can use in your clinical and hopefully research work. So 7 of them. The first 2 are lengthy and take a long time. So if it seems like, my goodness, he's only on number 2 and we're already well into the talk, don't worry, some of them go a little faster. This is number 1, and it's an important one. We could spend all day talking about developmental issues. But as anyone working in the field, if you're going to try to exert behavior change and be a behavior change agent for a young person, you've got to try to keep in mind the important developmental aspects. I always remind counselors, you have to sort of enter this arena, working with teenagers, remembering that to some degree, you're the enemy for a young person. They're actually trying to break away from adults. And here is a situation where you're an adult trying to tell a teenager what to do. It's not the best dynamic to establish rapport. It's a little easier, I think, when you have adults talking to adults. I always tell administrators, you ought to pay your adolescent counselors more than the adult counselors. I think they got a lot harder work to do. I think it's more challenging. At one level, it's also somewhat difficult to figure out, well, if I got a clinical problem with this teenager, or do I just have something that's typical with adolescents? Parents aren't very good at identifying it, and often they're sometimes the first line of a red flag, getting a call or an alert from an adult or a parent saying, my teenager must have problems. I'm noticing things at home. Well, typical adolescent behavior can be exhibited by a lot of roller coaster type phenomenon, including risk behaviors, high emotionality, changes in various patterns, whether it's sleep patterns, changes in interest in peers, etc. And some of these can be confused with drug abuse because also drug abuse can trigger some of these same symptoms or characteristics. Just to remind you, it's natural and normal and even healthy for a teenager to exert some 2 key psychological phenomenon of individuation and separation. This can puzzle us as therapists, may frustrate us to some degree, but also can lead to parents being frustrated. So they see the teenager pushing away, they see the teenager trying to develop different identities over the course of a short amount of time. 1 year in school, they're hanging out with one kind of friend and having a certain identity, and then perhaps another year, they've changed that identity. That may puzzle parents, and it's a somewhat interesting and curious phenomenon, but in many ways it's fairly normal. A little bit about what drugs teenagers use. Just want to have you keep in mind that while there is a lot of profile about exotic illicit drugs having a health problem with our culture, including youth, keep in mind that still the 3 most common drugs of abuse by teenagers, and this has been the case throughout the years, even though we've gone through crack cocaine epidemics, so-called methamphetamine epidemics. For teenagers, it's still pretty much alcohol, cigarettes, the 2 legal substances in our culture, and marijuana. So for illicit drugs, marijuana has always been number 1 for teenagers throughout the years, and it continues to be. I'm showing you here some changes from 2001 and 10, and all of them are in the negative direction. You can see there were some nice improvements in alcohol and cigarette use. Cigarette we're probably winning the biggest battles with teenagers, from a high of almost 30% of abusing cigarettes down to 20. That doesn't mean they're daily smokers. That's not a necessarily daily rate. I put 2 other drugs on there just to highlight for you that when you list other drugs, you get much lower prevalence rates. But interesting, in the last 2 years, there is a trend we have to worry about that tends to put the 3 profile drugs, alcohol, tobacco, and marijuana, on the back burner, and that has to do with the abuse of prescription drugs, particularly the pain medications. And this has now been profiled over the last couple years in national surveys. This is data from the Monitoring the Future study. You may know about this annual study of 8th, 10th, and 12th graders, so it's very representative. It's self-report, but it's interesting to see trends, regardless of how you feel about the validity of adolescent self-report. Looking at trends is still, I think, valuable as we try to understand what teenagers are using. So I've colored for you the medications, so-called prescription medications that teenagers are using. You can see that they are starting to move up in the list of most frequently used drugs above and beyond alcohol and marijuana. So years ago, they were not on the list like this. They were buried down in the 1% type frequency, and now we're starting to see them emerge. The other thing that's happening when you now ask teenagers, what's the first drug of abuse in the illicit category that you're using, if you are using an illicit drug? So now I mean not alcohol and tobacco. It's always been marijuana. As I said, that was, the most popular. Well, it now turns out we're starting to see pain-relieving medications, that whole group, OxyContin, Vicodin, et cetera, that's vaulted ahead of marijuana for first drug, illicit drug of abuse, the so-called initiative drug. Kind of interesting. Showing its prominence now in the lay of the land of adolescent drug abuse. Something to deal with in our clinical settings, because where are teenagers getting some of these drugs? Well, often at home, because parents are not aware of it. Another question, what is the extent to which teenagers are showing a clinical problem of a substance use disorder? We tried to look at this with national data. So we took a national survey that was done 2005. It fortunately assessed for substance use disorder criteria, abuse and dependence. You can see how it breaks down when we looked at not only those groups, but some other groups. So these are mutually exclusive. So if you go to the simplest way to read this, go to the far left. If a teenager met dependence criteria, DSM-4 defined, for any drug, they got in the dependent box. And then if a teenager that were remaining in the data set met diagnosis for substance abuse disorder for any drug, and then they got put in the abuse category. And then for the remaining ones, we would look at other breakouts. Heavy drinking, binge drinking, illicit drug use, light drinking, and non-user. So all mutually exclusive and from most severe to least severe. This is combining 12 to 18-year-olds. So keep that in mind. You might look at the far right bar and say, whoa, that seems pretty high. I thought teenagers used a lot of chemicals when they're growing up. Well, there's a lot of 12, 13, 14, 15-year-olds in the sample, so they're contributing heavily to that 65%. If I just looked at males that were 18, if we just slice it that way, you'd see the bar is quite different in a predictable direction. You'd see a lot higher reds and yellows and a lot lower greens. But so for substance use disorders, abuse or dependence of any drug, you might make a case that we're now talking about 11% of teenagers. Some of them had multiple dependence criteria met, or multiple abuse that isn't factored in there. So that would, of course, add to our view of severity. More on what that means. So you have that as a teenager. What happens when you're growing up? How many grow out of it? How many don't? More on that. But youth is a vulnerable time of one's life for substances. It makes sense that we have prevention programs focusing on teenagers. It makes sense that we try to expand our treatment programs to address this population, because you can make a case in America, modern times, that in one's teenage years, you're probably going to use substances the most or at the heaviest level than any other time in your life for most Americans, at least current modern view of the picture. This is one way to look at it. So if you took a snapshot of America, this was done in early 2000s, asking people in a survey if you have a problem with chemicals and does it meet certain diagnostic criteria. So I'm just showing you the rates of dependence. So this means the person said within the last year, that means that's recent, did you meet criteria for alcohol dependence? And here's how the percentages break down. So where do you get the highest percent? In the youngest years. And as people were older, fewer of them, proportion-wise, suffered from a dependence disorder. Now, some of the people in the older group had perhaps dependence disorder when they were younger. This is again taking a snapshot, looking across ages, and looking at just recent. A lot of other ways to look at the intersection of youth and vulnerability to drugs. This is another way data has been looked at. So based on SAMHSA data, this is now taking adults in the sample and asking adults about alcohol use and when they started and if you had a current problem. So this is the intersection of those data points. The way to read this slide is go to the far left. So the 16% means that among the adults that said they used alcohol for the first time in their life to the point of getting drunk, age 12 or younger, 16% of them had a current, past year, current problem with alcohol, abuse or dependence. Then you can see how the rate of that current problem varies, goes down, as a function of delaying the onset of use. So to the far right, you could make a case, if you wait till legal age to use alcohol, you have about a 7 or 6-fold reduced likelihood of having a current problem as an adult as opposed to if you used alcohol early in your life, age 12 or younger. Suggests youth is a vulnerable period. Earlier you start, the more likely you do have a problem as an adult. This is another way to look at the youth years. So we took similar data sets and just looked at how onset of use was related to then getting an adolescent problem with alcohol. And we found that the older that you started to use alcohol, or the later your onset, the less likely you were to develop a problem within a 2-year period. This is looking at a window of 2 years of having a problem. And you can see that the base rate, or the probability of having the problem, is much higher the earlier you use. So you're going to more likely to get then a problem within 2 years if you start in the earlier part of your adolescence as opposed to waiting till later. Just another reflection that youth is an interesting, vulnerable period, and it surely speaks to the importance of prevention and treatment services. Another feature on developmental aspects I want to bring to bear is this new science on brain development. This is an interesting emerging science. Significant findings from this are, I think, have a lot of impact on how we view adolescents in a clinical setting and how we want to think about treatment. One of the main findings was that the brain continues to develop in a significant way until about age 25. So that was fairly new finding. And the way the brain develops is also important. It turns out that the emotion regions are developing a little sooner than the common sense region. So that cartoon I showed you does reflect the brain science finding. This is a time-lapse representation of what's called synaptic refinement or pruning. This is a process that occurs heavily during adolescent years. It actually doesn't end until about age 25, but this is showing the major parts of that process from 5 to 20. Pruning is getting rid of clutter in your brain during adolescence. You're actually losing net connections during the teen years. That's okay. You're not losing intelligence. You're getting rid of clutter and making the brain stronger and more efficient. That's the explanation for it. But it doesn't occur uniformly. It occurs differentially across regions. And the part of the brain that is getting pruned sooner during the teen years has to do with emotion and motivation and reward seeking. The part of the brain that's a little later in all of this efficiency process is the common sense or executive functioning. Or I call them the brake regions that tell you to resist impulses and delay gratification. Prefrontal cortex, which is that portion right here is roughly the last part, which is the home or the seat of sober second thought. One way it's described. If you ever hear a teenager say on second thought, whoa, oh, that's a great thing, reward that teenager, because it's supposed to be kind of rare or difficult for their brain to do that. So they might be ahead of the curve or a good precocious individual. You want to get teenagers to do more on second thought type things. It's because you tend to not do it as well in your teen years as your capacity to do it when you're an adult. And of course we all vary on that trait. It's probably something that's normally distributed in a culture, the ability to resist impulses, but the odds are for every individual you just weren't as good at it, and you might have been subjected to perhaps a lot of contextual factors that led you to be more impulsive in your teen years as opposed to as an adult when you're able to weigh in a little bit better, have some sober second thought, weigh consequences, and then make a decision without being as impulsive. But of course it's a relative thing. But it is interesting. We have a period of development where risk-taking and other kinds of features are probably going to be more common. This is our effort to synthesize the developmental psychology literature on what this brain science means in terms of behavior. So we read Ron Dahl's work, Lawrence Steinberg, Linda Spear, etc., and because they've weighed in on what some of this science might mean for our understanding of teenage behavior. So if you look through 1 through 7, you should see a lot of features that make sense, because this is supposed to be pretty much normal of what you see among teenagers. If you reflect upon yourself, you might see yourself in that list. But I think if you look at the list, you come away realizing, well, it looks like that's a time of life where reward incentives probably win out over perception of consequences. Second thought isn't as good. Impulse control not as good. Or delaying gratification not as good. And there's some contextual factors up there as well. The important one, I think the literature is starting to spend some time with, is number 3, how peers can heavily influence this. So you might have a certain impulse base rate during your teen years. And let's say it's not really all that problematic. It might be, again, a little bit different than how your impulsivity control will be as an adult. But let's say you're kind of showing a typical teen impulsiveness, a little bit edgier, a little bit on the high side. But you give certain contextual situations that might trigger then certain decisions or behaviors that can lead to risk. And one of these contextual factors is peers. With peers, particularly like-minded peers that also kind of on the edge with their impulsiveness can contribute to problems. From a empirical standpoint, and if you know anything about the drug abuse field or the delinquency field, you know that that's a key factor, isn't it, of adolescent drug abuse and adolescent delinquency. It often occurs with peers that are also engaged in similar behaviors. We all are impacted by our friends and our peers. There's a lot of science on this. So it's not unique just to the youth years. You may know that there's a science that suggests you probably would act a little bit riskier within your comfort zone of taking risk when you're with your friends as opposed to if you're by yourself. There's some science on that. And you can demonstrate this in the lab with adults and teenagers. It's just that with teenagers, they are more subjected to it. They show even a greater risk-taking response with their peers, where adults are at least moderating it in their comfort zone. There's also one other spin on brain development, an interesting look at how this relates to alcohol use and alcohol risk. There's a series of studies that have tried to examine this. They're all indirect because it's difficult, as you can imagine, to look at the impact of developing brain and alcohol in any direct way. You can't give alcohol to youngsters in the lab and measure its impact. It's not going to happen. So animal models as well as inferential studies have been offered up to try to look at this question. The big question has been, are adolescents more susceptible to the effects of alcohol than adults? Is the developing brain, as well as other developmental characteristics, contribute to greater susceptibility to the impact? And one series of studies has looked at the differences in acute effects of alcohol developmentally, and it looks like there is a difference based on animal models. So using rats, for example, you can show that an adolescent rat is more sensitive to the negative effects, more sensitive to the positive effects of alcohol and less sensitive to the negative effects of alcohol compared to adult rats. So adolescent rats, they can drink more before they pass out compared to the adult counterpart. The adolescent rat doesn't show as much disruption in motor coordination compared to the adult rat in the studies. Those are two acute effects. So if you're less sensitive to the acute effects, that might, from a human standpoint, embolden you to keep drinking because you don't think you're drunk, because you're not feeling drunk. You're not having the gross impact. You might still be too drunk to drive. You might be too drunk to make good decisions, to get out of a compromising situation, et cetera, et cetera. But if you're not falling down, or you're not getting tired, et cetera, you might not think you're all that intoxicated, so you might keep on drinking. The other thing, it looks like social behavior is impacted significantly different in the developmentally. So adolescent rats show a greater sensitivity to the social effects of alcohol than adult rats. What are those effects? You're more friendly, you show social disinhibition, you want to hang out with your counterparts, rats, or your friends. Rats play fight when they're sociable, and so adolescent rats do more play fighting when intoxicated than adult rats, for example. Greater impact on the social side and less impact on the negative side sounds like a bad recipe. There's also literature looking at memory impacts. Correlational studies, I'll just show you two of them. There's, of course, the big caveat, because we can't rule out other causal factors with these, but one set of studies looked at the impact of memory on two groups, one that had a history of alcohol abuse, one that's a control group without that alcohol background, and there was less memory by about 10% in the alcohol disordered group. Is that causal? Is that because that one group had alcohol history and it did damage to the hippocampus? You can't say for sure, right? There could be memory deficits that preceded the alcohol use and they didn't have the luxury in this sample to study that. But it was provocative enough that it's now led people to realize, let's do some longitudinal studies to see if we can try to better tease out causal effects. One other correlational study looked at hippocampus volume. You may know that's the region of the brain heavily associated with memory performance in general. Hippocampus size is related to your memory ability on memory tasks, generally speaking. So anyways, another sample of teenagers. One had a history of alcohol dependence, one without. They measured hippocampus volume, and on average, there was about a 10% less volume in the alcohol disordered group, the group on the left. Small sample size. You can see there's a lot of individual differences there, crossover variation with the two groups, but on average, there was smaller by about 10%. Provocative. Interesting in the negative direction. Now, why would people look at hippocampus and memory? It makes sense with alcohol, because chronic alcoholism can lead to dementia. It's known the toxicity of alcohol can particularly target the memory regions of our brain. So it does make sense to look at it. And people are wondering if the developing brain, which is in some degree vulnerable perhaps to toxicity, as opposed to a developed brain, might be more subjected to the adverse impact of alcohol. And so these kinds of studies are getting done, and in a few years we'll know more about whether we can draw some more causal inferences. Okay, second feature I want to emphasize. Counselors in this field that I think appreciate that, yes, treatment works. It doesn't work for everybody, but if you follow some basic principles, you have a wonderful opportunity to impact a young person's life in a healthy direction. And so I want to now spin perhaps the biggest core section of my talk by discussing what we know about treatment effectiveness. And I'm going to draw heavily on two things. One is the Lipsey meta-analysis, and then I'm going to sprinkle in more individual studies, both from our shop and others, that also help round out our understanding of treatment impact. So there were two meta-analyses conducted by Lipsey that are in this report. The first one examined 55 studies, experimental or quasi-experimental. A few of them compared a target treatment or focal treatment with a no treatment control, but that's rare. Most of them are comparing a focal treatment, target treatment to something as usual, whatever was going on in the clinic or in that setting, or it was a horse race between two separate. You can imagine it's difficult to have no treatment or assessment only controls when you're doing these kinds of studies, and it was the case when he looked at what was out there. From those 55 experimental, quasi-experimental studies, he was able to generate almost 320 group difference effect sizes. The second meta-analysis was a little different. Here he took 69 studies. He had a little bit larger group because here he decided, let's just look at pre-post, baseline to follow-up. So he's got 69 studies because some of those studies didn't have any comparison group, so that wouldn't have been in the first meta-analysis. But it's informative to see how people are doing pre-post, even though if you don't have a control group, you might not know if that's any better than doing nothing. But it was informative. So the 69 includes many of the 53. Anyway, you can read the full details of the design and about all the studies and where you can look them up if you want to. So we've taken the meta-analysis and tried to synthesize the big picture from it. So we looked at what are the themes, and so I'll spin that for you now. Just keep in mind, this is a field that hasn't yet had the opportunity where people have rigorously compared multiple treatment approaches in one study that was that met standards of a randomized controlled trial. You may know about something called Project Match. NIAAA funded a major effort to try to compare, this is an adult study, but try to compare different treatment modalities with random assignment, highly controlled conditions. Had multiple sites all over the country engage in this, and that was a great opportunity to see if, when in an effort to compare different treatment approaches with one major research design under the control of one group of researchers, what does one find? Well, we don't have that luxury in this field. So you have to keep that in mind. We don't know with horse races of family-based versus 12-step versus CBT versus MET, who wins. We've just got, sometimes people compare 12-step versus something, or CBT versus family. Often they're just pairwise comparisons. Anyway, just keep that caveat in mind. But, so what happens though when, there were some comparisons, and there were, obviously you could look at the pre-post. What did Lipsey come away thinking? He realized when you look at the big picture, the body of work suggests that the overall pattern was positive effects for all treatment models when compared to comparison conditions. The quote from the report, diverse treatment models or approaches were at least somewhat effective. So there's a fair variety out there. No one program clearly emerged to the top. However, he goes into detail. There are some that look a little better than others. So if you had to hedge your bet, or you had limited resources, or you were wanting to hone your skills and you can't get skills in everything, it looks like family therapy, as well as either the CBT or the CBT-MET are the ones that provide the best benefits. CBT, cognitive behavioral therapy, and often when people do CBT, they mix in MET or motivational enhancement therapy. And you'll hear about more of that later with some of these interventions. But family therapy, important, as well as some of the great technology we've learned from cognitive behavioral therapy. So, but that was a slight tendency. If when I give this talk in Minnesota, I am from the land of 12-step programs, home of Hazelden, etc. I remind them, well, the 12-step, first of all, wasn't heavily represented in those 63 studies, because not a lot of people are studying them in a rigorous fashion. When studied, they look pretty good, but boy, there's too many other studies out there that are looking at family and CBT, and they're showing significant benefits. So it's always my push at home to encourage even the 12-step programs to insert as much CBT and family therapy in their work. More on the Lipsey report. With some exceptions, treatments showed relatively equal effectiveness across groups defined by ethnicity, gender, and age. I think the one tendency for the exception is older teenagers doing a little worse in outcome than younger teenagers. Length of treatment was not related to outcome, but because most studies didn't have options for randomly assigning to different lengths of treatment, and length of treatment can be impacted by all kinds of things. How much resources did the research study have to have lengthy or not lengthy treatment? How much was insurance coverage perhaps interfering with length of treatment in some of the studies that were more naturalistic? Did individuals with severe problems not get into some studies because they met exclusion criteria, but in the real world they'd be in our clinics, because that's why they're in our clinics, because they got the severe problems. And so you may not be able to look at an important issue of length of treatment with some of the severe end cases. So length of treatment might have a role. It's very hard to tease out. And there was a general trend that adolescents with higher levels of drug use problem severity, not the coexisting problems, that's an issue I'll tackle in a moment, but the higher levels of drug use problem at intake showed greater reduction. Of course, that might be a statistical phenomenon, regression to the mean. You get the higher end at the front end, you tend to get more improvement, more dramatic improvement statistically at follow-ups. But that did show up in the study. One marijuana facet he highlighted: youth with chronic use of marijuana revealed less positive treatment outcomes compared to those who abuse alcohol only or who were moderate abusers of marijuana. The sub-bullet there is my interpretation. Lipsey didn't delve into it, in part because he doesn't have the data from these studies to do it, but it strikes me that one of the reasons for that might be because the heavy marijuana users are bringing with them more of the coexisting problems. So go back to my first slide. My hunch is you might see more of those coexisting problems tagging along with the heavy marijuana users. That would likely negatively impact treatment benefits. But because a lot of the studies didn't do a good job of measuring coexisting disorders, or if they did it, they didn't report it to the point where Mark Lipsey could insert it into his meta-analysis, we aren't sure about that finding. Okay, some other issues related to treatment effectiveness. I've cited a chapter in a book, but some of these issues also come from other discussions in the literature by experts. There is a growing interest in trying to understand the role of pharmacotherapy for recovery of addiction in the adult arena, and it's also making its way into adolescent treatment. You may know there's a significant group of medications trying to help with reducing urges for alcohol abuse, and now there's also the buprenorphine or Suboxone trend or movement that's also getting addressed with teenagers. I think you're going to see more of this. There's more studies that are including either older teenagers or young adults, and there are more treatment programs that are willing to go down this route. It's somewhat controversial. The odds are we're just going to see more of it. And healthcare reform might promote more of this, because healthcare reform might move a lot of substance abuse treatment into general practice settings. If that's the case, the general practice settings might show a bias towards medications as at least a frontline form of treatment for various reasons. I'd stay tuned with that one. Well, what about adolescent findings compared to adult findings? Actually, it's fairly similar, roughly similar, in terms of percent abstinent or percent improvement. Here's a slide put together by Sandra Brown and her shop. So you have 3 lines up here. The red is the adult project match that I mentioned, so that's adult data. The green one is a version of project match, just the outpatient sample, and then the white box are the adolescent or the teens. And you can see the survival rates, this is percent losing abstinence. You can see the teens are kind of in the middle, hovered right there with adults. So fairly comparable. It does speak to the chronicity of the disorder across all ages. I think there's emerging evidence that recovery is linked to the extent to which coexisting disorders exist. Conduct disorder, ADHD, oppositional defiant are some of the common ones. Sandra Brown was able to find some studies that showed teenagers with comorbid disorder and their outcomes based on teenagers getting treatment without comorbid, and they show the poorest benefits. Perhaps not surprising. Individual studies that have looked at it, I don't remember one study we've read or done ourselves where we didn't look at it and we didn't find that principle. However you want to cluster kids of having either no coexisting or sort of low, moderate, or heavy, you find the relationship in the expected direction. Coexisting disorder does negatively impact treatment effects. Well, why might that be the case? Is it possible that a lot of treatment programs don't help teenagers with those coexisting disorders? And I would make a case that is true. Some programs are just focusing on the drug use and getting kids to, do a better job with resisting impulses and getting new peers and learning about the addiction principles, etc., and not helping them with their ADHD, depression, anxiety, etc. Well, if you add coexisting treatment to teenagers with coexisting disorders, you do improve treatment. This was a study done from Kaiser Permanente data set, and you're seeing the higher abstinence rates. So the yellow bars are higher than the orange bars. Well, the yellow bars mean the abstinence rates for teenagers getting substance abuse treatment and treatment for coexisting problems. So the psych treatment there, the label really means chemical dependency treatment and psychiatric treatment. And the orange bars is just chemical dependency treatment. So it does make sense. If it's logical, treat the other disorders, you surely can help teenagers with their recovery. Treatment retention is a problem. It's probably more of a problem with teenagers than with adults. Here's a national data set provided from Michael Dennis at Chestnut Health Systems. So this is national data. Basically, the way to read this very complicated chart is just go to the top bar, and all the pretty colors, the bright, friendly colors of green are good news, and all the orange and red is bad news. So you see a lot of orange and red. It's roughly, what are we getting? Only about 49%. You could make a case of teenagers either completed treatment or they were transferred to another program, which meant they were still probably in the treatment system and not having left. The orange and red represent teenagers that were discharged against staff advice or against doctor's advice. So we're really only our batting average is about 50% of getting teenagers to stay in treatment to the length at which we think is appropriate. Obviously, that's a debatable concept in and of itself, but we probably have a retention problem, and that might have to do with motivation, developmental issues, treatment programs not being teen brain friendly. We talk now, I used to talk about, well, let's make sure we're using evidence-based practices. Let's make sure we're taking advantage of CBT and MET. But we also now talk to programs about sharpening up their view of the treatment approach to make it teen brain friendly. And I think MET and CBT are teen brain friendly approaches. But if you're a 12-step program, like we have a lot in Minnesota, there's a lot of things you can do to that to make it teen brain friendly. You have to, for example, you can't have a lot of lectures. Lecturing is not captivating to a youngster. But if you make the learning principles within a context of active learning, where they're either play acting, they're doing skits, they're role playing, make sure group is very active with discussions. This is going to help the teenager with the learning. It's, I think, more accommodating to the adolescent brain. Some other challenges we all have in this field. Typically, teenagers are returning to the same environment that they left, and that environment usually has all the triggers, the bad triggers. So how many teenagers get to go to a school that doesn't have youngsters in that school that promote drug use or have drugs available? That's pretty rare. How many teenagers go find new friends that aren't drug users? That's pretty rare. How many can go to a home that's perfect for recovery? All these things are rare. You can't control the recovery environment as a teenager in the same way you can or have some options as an adult. So these are difficult barriers for us. The one little sidebar phenomena that's going on in some parts of America are these recovery schools, recovery high schools. It's an opportunity to try to get a school more recovery friendly and to build aftercare around the needs of youngsters in recovery. They're pretty rare. I think there's only about 25 or 30 of them in the country. Also difficult to find youth-friendly self-help groups. This is trying to get teenagers to extend their aftercare by having a sponsor and benefiting from the support of others. It can be difficult if that self-help group isn't adolescent friendly, and they are rare. In major metropolitan areas, you can tend to find some that have at least a youthfulness feature to them, but if you're not in a major metropolitan area, it can be very difficult. A little sidebar. So what happens when you follow youngsters that meet substance use disorder in their teen years and you look at them in their 20s and 30s? Roughly 3 studies have looked at this, and all of these have been able to follow up youngsters into their late 20s and early 30s. And if you look at the body of work from these studies, we came away with this basic conclusion. About a third are unfortunately continuing to have problems. It's a waxing and waning, but continuing to use, perhaps even escalating their use. But the other 2/3 are much better. You could make a case there's a mixed group, that 1/3, I call it variable problems, but they're usually, in most instances, with most data points, showing improvement. And then you had 1/3 that really looked like they grew out of whatever was going on in their teen years that led them to heavy use. They grew out of it. And some of them had returned to so-called social or healthy alcohol use, although I guess if we were to measure some of that on college campuses, we might not think their typical adolescent or college student drinking was healthy, but they were returning to what you might call more normative use. Okay, number 3, appreciate that level of treatment should match the intensity of problems. It's important to think about applying the treatment technology and the resources you have based on level of problem. This is a rough gauge of how you might look at it. As I mentioned, you can make a case that you have about 5% of teenagers meet abuse criteria, and 20%, however, are heavy drinkers or other illicit drug users. So there's about 25% you might make a case could benefit from brief intervention. They don't have a severe enough problem for intensive treatment, which we might want to allocate only to the most severe cases, for example, those meeting dependence. And so treatment should be modulated. For example, for brief interventions, when you look at the ones in the field, you see them vary in intensity. From 1 to 4 is common. Most of them use motivational interviewing and cognitive behavioral therapy. And the feature we like is negotiating goals. So you modulate it based on where the teenager's head is at, and you figure out goals that look reasonable and doable for the teenager. We try to aim for abstinence eventually as a goal, but we might not have that as the frontline goal. It is more controversial, isn't it, though? If you're negotiating goals with a teenager that's short of abstinence, you have to be careful of that. Most of them use decisional balanced exercise, or the pros and cons method. I'm showing you this slide because if you only have a short amount of time with anyone who's using drugs, this would be the one thing I would do. Try to do a pros and cons interview or engagement with a person. Ask them about why they like, you always start with, why do you like to use? What are the good things about your using? And get that information. It's very valuable. It tells you the functional value of the underlying behavior. If you're using because you're bored, using because you have attention problems, because your friends, it makes you feel more socially comfortable. All that is clinically useful. And then try to see if they have any negatives, see if they have a point of view on it. That's also leverage for you. But in a 10-minute interview using this, you can get a quick functional analysis and quickly come to some perhaps goals or strategies for that person. And so most brief interventions use this approach. There are 2 of them listed in NREP, the National Registry for Effective Programs and Practices. It's a national database that tries to help us in the field figure out what are effective evidence-based treatment programs. Without knowing the literature, can I go somewhere where someone else has figured out what are the good ones or not? And so this has been a system in place for quite a while. It's probably on its 4th edition. It's going to get updated, but the good news is if the program's listed, that meant that it had to have been researched It had to have been researched with a fairly rigorous design and shown that its outcome was positive above and beyond something else. So it couldn't just do a pre-post, for example. Anyways, there are two of them that I would call brief interventions because they're in the 1 to 5 or 1 to 4 category, listed in NREP. The brief family therapy from Holly Waldron's group in Oregon, and then our Teen Intervene. If you're around this afternoon or later this morning and this afternoon, you'll hear about Teen Intervene. So what about intensive treatment? That would be now all these options and models and approaches for teenagers that are to severe end. In NREP, here are the 8 that are listed. They are an interesting mix. Some of them are extremely intensive, some of them are less intensive. There's one of them that's 12-step, but it's not Minnesota model 12-step, it's 12-step facilitation, which is a way to do 12 steps one-on-one with a person, not in the usual approach where a group of people are all getting the 12-step approach. So to try to give some meaning to this, we looked at those 8 programs and tried to figure out what's common among them. So we came up with what are core features. And here's our list. This doesn't mean they're evident in all of them, but they're features that are present in most, and sometimes all of them. A lot of good common sense features, focusing on skills, focusing on what teenagers probably need. You can make a case, let's see, the first 3 are all related to skill building, coping, dealing with challenges, social issues, how to deal with lifestyle changes when you get out of treatment. How are you going to have a fun social life and still be a teenager and enjoy life, but you might have to change how you relate to your friends, or you might have to change how you're going to enjoy free time. So a lot of programs do step work. They might not call themselves a 12-step program, but they will work with the steps, because most of the steps are organized around 2 features. And to some degree, I think they're teen-friendly. One feature is you should lead a life of abstinence. Now, some programs are willing to say, well, when you're 21 of legal age, you can revisit whether alcohol might be suitable. But abstinence is the main theme. And the second one is you need to rethink how you're leading your life, because your life is filled with a lot of bad decisions that's leading down a bad path. So you got to rethink your values, your friendship patterns, how you have fun. It's kind of telling the person you may need to sweep with a new broom. And to some degree, some teenagers need that, at least need to think about it and come up with some options to get them out of unhealthy pathways. Fortunately, most of them do address mental health issues, and then most of them do have family programs to lesser or greater degrees. And it's common to have programs deliver individually and in group. Group counseling, I think, is excellent for teenagers. You've got to be a good therapist for it, but teenagers can learn from others. You've got to make sure they don't learn the bad behaviors, but they can learn from others, and a lot of teenagers aren't all that articulate or verbal, and it can benefit hearing something from another teenager. The power of another teenager saying the right thing versus you as the adult saying it, well, it might be exactly the same thing, and maybe you even say it in a cool way. Try to say it in a cool way. I don't think it's as significant as opposed to when a teenager says it for you in group. They can be your ally, some of those role model youngsters. Number 4, I got 3 to go. These all go fast. Don't rule out the importance of assessment even though you're doing treatment. You want to have good assessment up front so you can figure out who's got a mild problem or who doesn't, or who has coexisting problems and what are they, and are they severe or not. You can have mild version of ADHD, and that doesn't mean you have to address it. Maybe it's even subclinical, short of a diagnosis. Well, you don't clinically have to deal with it in the same way as if you have somebody they meet diagnostic criteria for ADHD, and it's a significant problem for them. So it surely translates to treatment decisions. Now, in your handout, you can't tell what's green or black, but on the screen, I've colored the green. Why are they green, the ones listed like that? It's because they are not freebies. They cost a little bit, the ones in green. Some of them are only $1 or $1.50. Some of them you pay once, maybe to get the software with scoring, you pay a $300 one time and it's unlimited use. So some of them are I think, good bargains and good value. But the list is the ones I like, not because of the cost issue, but because they are well researched and were developmentally designed. And there's still people around that are there to help you with issues in their use, so that and even being updated. You know, for example, the GAIN is being updated all the time. The PESC, the SASE, updated. Anyway, I just want to highlight the 6-item screen for you, public domain. This is a great screen to insert into your clinical practice. So maybe you don't see that many drug abusers. You're a general adolescent child clinical practitioner, but you want to at least see who might have a problem so you can further refine treatment approach. Here's 6 items. 2 or more means you might want to address it, do some more investigation. So for 6 items, 5 minutes, you can do a pretty good job of figuring out who might have a problem. You're not wasting too much time, are you, for maybe detecting the 20% or whatever that's coming in your clinic that might have this as an issue. If you read through them, you can see they're kind of logical. Don't worry about if it makes sense or not, and if a typical teenager that you think about would answer yes or no. The validity data behind it is very strong. So it's about an 85 to 90%, depending on how you cut score, accuracy. 2 or more means a person at 80 to 90% likelihood has either abuse or dependence criteria. So if you then go through and do a formal DSM-4 assessment of the person, and they've had 2 or more, the odds are 80, 90% level, you're going to either get abuse or dependence for at least one drug. And, if you have somebody 6 out of 6 or 5 out of 6, the odds are it's dependence and maybe even 2 drugs. There's a little bit of that going on. Just to remind you that one free tip, number 31, that also has a lot of background on some of those instruments on my favorite list. Number 5, be prepared to deal with comorbidity. Here's some of the common disorders in clinical samples. So if you're working in an outpatient or inpatient clinic, the odds are you're going to see youngsters that are abusing drugs also have other problems at a very high base rate, and here's some of the common ones. So the 2 externalizing tend to dominate, but the depression and anxiety disorders are also there. I don't have percentages for the others because there's just not a lot of data yet from enough studies to give precise estimates. But I've listed the ones that do get cited in the literature. Some people have tried to figure out why. I'm not going to go in great depth of this, but why are the 2 bundled together so often? And one theory is that there's a common set of risk factors that precede the onset of both types of disorders, both clusters. And in many instances, the coexisting problem that you're trying to understand that you think is tagging along with drug use actually preceded the drug use. Because oppositional defiant disorder, conduct disorder, ADHD, and oftentimes depression, anxiety disorders in these youngsters are the early onset versions. They're getting onset at age 10, well, some of them at age 8. And so some of these disorders are preceding, and thus when the teenager gets old enough and gets some access to drugs and gets some independence and freedom, gets into a peer network, the drug use is helping medicate or is a coping approach or strategy by the teenager. Thus you get the substance use disorder, SUD, substance use disorder, and that tends to accelerate the person's problem. So you might have common thing is OD, oppositional defiant disorder as a teenager. They get involved in a delinquent peer group and using drugs, and all of a sudden they've escalated their behavior and they're meeting criteria for conduct disorder. And ADHD can follow the same problem. Another sidebar. A trait that we might want to be researching heavily is, however you want to word it, this group of researchers defined the construct as self-control or emotional behavioral regulation, another phrase. It looks like it's pretty predictive. This isn't treatment outcome. This is just looking at self-control measured at childhood and the likelihood of having an adult problem with substances. And you can see an interesting relationship. The people with the individuals with the best self-control as children had lower likelihood of an adult substance dependence diagnosis. Those with the the poorest self-control, the biggest risk factor, they had the highest rate. So that could be a core risk factor preceding disorders and preceding drug use. So targeting that prevention treatment-wise would surely make a lot of sense. There's some interesting data on the intersection of early drug use and how much it creates or causes mental illness. You could also look at pathways that way, couldn't you? How much does it contribute to onset of mental illness that might not exist preceding the drug use? So moments ago, I was talking about a pathway where, it's likely some individuals, there's a pre-existing disorder in childhood and the drug use is following that, is maybe a consequence, if you will. But what about where there's not a pre-existing disorder, but then there's drug use? Could mental illness emerge later, and could that drug use contribute? Very difficult to study this, as you can imagine, and to nail down that causal pathway. I'll just show you two data sets that people have looked at and said, whoa, this is provocative. Now, this is one that is asking adults about their history of drug use and whether they have current mental illness problems. And this is the relationship of marijuana use as a function of how early one started to use. And you can see that the rate of adult problems is the highest based as a function of the earliest one started to use marijuana. That's kind of provocative. Early marijuana use, did that trigger phenomenon, perhaps in a vulnerable, high-risk individual on a pathway towards mental illness that wouldn't have happened if they hadn't used marijuana? Is that possible? You can't tell for sure from this data, right? But it's provocative in that direction. Here's another interesting finding. This is the Archives of General Psychiatry recent publication from an Australian group that did a meta-analysis trying to look at the intersection of drug use and mental illness. And there's enough studies where they could do a synthesis and look at age of onset of mental illness as a function of drug of abuse. Here's the three ways they broke it down. You can basically come away from this analysis saying, well, if you were an alcohol abuser, that didn't have any impact on how early your mental illness would onset. So it's age of onset of mental illness is a dependent measure here. But if you used marijuana, the age versus controls that didn't use marijuana, age of onset of the mental illness was about 2.5 years earlier. So the marijuana abusers had mental illness onset 2.5 years earlier in their life than the control group, which is people who had mental illness without the marijuana history. And then any drug on the far right, any illicit drug, you showed also a significant impact above and beyond control. It's kind of interesting, provocative. The article basically harpoons marijuana and says this is a dangerous drug for vulnerable individuals that might have a predisposition to mental illness. Whoa, this data is scary, provocative, and is an important public health warning. Of course, I don't think the state of California has looked at that data. Okay, number 6, 2 to go. They're very quick. A reminder to be teen brain friendly by shaping it as best you can to optimize many of these developmental principles. So keep in mind that you could make a case when people are in a position to change, whether they be voluntarily asked to change or whether involuntarily they're being presented to you to change, they probably have a certain attitude about wanting to change. And many people come to clinics or come to the change process in pre-contemplation, that view that they really haven't done much thinking about change. And they might be with you as a counselor for other reasons, not because they've wanted to be there. It's great when you can have clients that are in contemplation, preparation, or action. That means it's more favorable for us and they might be more ready to change. My view is there's a lot of teenagers may come to our clinical setting in pre-contemplation. So some of our work has to be to nudge them out of that stage and get them to perhaps improve their problem recognition, improve their motivation to want to think about change. I'm a big fan of using motivational interviewing or motivational enhancement techniques to help with that. If you study that line of work, there's a lot of ways to summarize it. These are the 5 basic interviewing techniques used in motivational interviewing. I think it's a very adolescent-friendly approach. When it was developed and has really taken hold in the addiction field, it's been mostly, I think, originally thought of for adults, but it's got a lot of features that I think make great sense for teenagers. It's not therapist-centered. I think that's good for the teen brain. It allows negotiation back and forth between the adult and the teenage client. I think that's excellent for a teenager. You spend a lot of time asking the person about why they like to use. What's the value in their life of using? I think some teenagers think that's a trick question because they've never been asked that by an adult, but it's a great entry point to open the doors, and you get a lot of good clinical information from it. And then I'm also want to reemphasize the importance of engaging parents. They are an important part of the solution. They might have been part of the problem, but they are very important for helping youngsters with recovery. And sometimes parents need to have their attitudes changed and improved towards a more pro-recovery approach about chemicals. Their behavior sometimes has to be adjusted also. And also they're so important in developing the home life that can be critical for recovery. So engaging parents is also part of getting that treatment to be adolescent friendly. And then just a reminder, drug use, whether it's with the teenager or with the adult, often can lead to a chronic behavior pattern. It may even be a chronic disorder as opposed to an acute disorder, and so it's going to be characterized by a waxing and waning pattern of recovery, relapse, lapse, recovery. It'd be typical for that to happen in teenagers, as it looks like it does happen with adults. So it's a tough sell to get teenagers to think about abstinence, but and they might have failures along the way, lapses and relapses, but I think it's an important principle for teenagers to think about, even if you're laying the mustard seed for the importance of abstinence, and getting them to think about it, I think is an important clinical step we want to take. Even though a certain percent of teenagers are perhaps not going to be abstinent, but at least in the short term while you're working with them. But it's a tough sell that you want to continue to work with teenagers. Okay, thank you for your time this morning.